Hey everyone, this is Brent Sherwin, one of the PGY5 residents, talking to you today about head and neck. Most of the information for this is from Savison's chapter 33, which unfortunately is a fairly painful chapter to go through. I also put a few additional things in from one of the ABSCITE review books, but again, this is not something we unfortunately do a ton in our residency, but it is sometimes on tests and could be something you could see on oral boards. So important to go over some of the basics again. Some of the details in the chapter I specifically left out because it was just too much and not very relevant to what we do. So some of the head and neck cancer epidemiology. So laryngeal cancer is the number one cause of death of the aerodigestive tract. There is a slight male predominance in these types of cancers. Biggest risk factor is tobacco abuse, so something you always want to ask about in your patients when you're seeing them. And then also alcohol abuse increases the risk as well. HPV infection and EBV or Epstein-Barr virus are two other things that can be associated with head and neck cancers. The chapter kind of mentions that you really need to split up the HPV positive and negative squamous cells, as they're kind of considered two distinct cancers. The other thing to note is that the HPV positive squamous cell cancers have a better prognosis. Squamous cell cancer is by far and large the most common head and neck tumor and most common tumor of the sinonasal tract. If you're faced with a test question and they're asking about the most common squamous cell, it's going to be a really good pick if you're not sure. Adenocarcinoma is the number one most common cancer of the major salivary glands, but again, squamous cell is the quotes most common of pretty much any head and neck cancer you're going to see. So your clinical workup, again, you do your history and physical. You specifically want to focus on whether they've had any numbness, cranial nerve weakness, dysphagia, dynophagia, change in voice quality, hemoptysis, epistaxis. And then you also want to inquire about tobacco and alcohol abuse and occupational exposures. Imaging, CT, just remember that it's better for evaluating bony destruction. So if you feel like the tumor might be involving the mandible or another structure in the face, CT would be better. However, MRI is better for the soft tissue involvement and the parotid and parapharyngeal space tumors. You do need pathologic confirmation prior to treatment, and this can be done with direct laryngoscopy or exam under anesthesia. There's also a bunch of different fiber optic scopes that a lot of the ear, nose, throat doctors use. One of the big things with head and neck cancers is the lymphatic evaluation. So the cervical lymph node basins contain 50 to 70 lymph nodes per side, which, if you think about it, is extremely impressive. They are divided into 7 levels. These are some of the descriptions here, so I'll go over these briefly, but honestly, I think the pictures that I've included from the chapter are honestly kind of the best way to review this. Occasionally, sometimes on tests, they may ask you which lymph nodes need to be resected with which type of cancer. So, unfortunately, it's something we need to know, at least the basics. So, level 1 is split up into A and B. And you can see the descriptions there. The important thing about B is it contains the submandibular gland. Level 2 is also split into 2A and 2B, and the kind of dividing line between those is the spinal accessory nerve. Level 3, 4, and 5 are kind of stacked on top of each other. Level 6 is central, and level 7 is in the superior mediastinum. One thing to remember about the lymphatic drainage is it usually occurs in a superior to inferior direction. So, for example, if you have a tumor of the lip or oral cavity, a lot of times it'll drain to nodes in levels 1, 2, and 3. Something that's weird about the upper lip is that it usually just metastasizes to the ipsilateral lymph nodes, versus the lower lip can metastasize to both sides because of the drainage. So again, here's the pictures. And these are important for if you're going to do a radical neck dissection or other dissection for associated cancers. For example, medullary thyroid cancer, to know which levels you're taking out and what structures are in the levels. And this is just a different view of some of the central lymph nodes. So therapeutic options for head and neck cancer, there's surgery, there's radiation, chemo, or a combination of all three. Early stage disease, stage 1 or 2, is usually treated by surgery or radiation. Later stage disease usually have to do a combination of all three modalities. One of the things you want to remember about radiation treatment is you want to be careful with neoplasms near the mandible, because if you radiate that area, the patients can get osteoradionecrosis, their mandible necrosis, and then you have to deal with a whole other issue. And also remember that many patients lose salivary gland function, which you might not think about on a regular basis, but it helps you with your taste sensation, and it can be very devastating for a patient to lose this. Radical neck dissection. This could be would be fair game if they asked you a question on orals or in the test about what's involved with the radical neck dissection versus a modified radical neck dissection. So it was first described in 1906 by Dr. Kreil, and the radical neck involves removing the following: so cervical nodal levels 1 through 5. The sternocleidomastoid muscle, the internal jugular vein, cranial nerve 11, the cervical plexus, and the submandibular gland. A modified radical neck dissection is all of the above, but you preserve the SCM, the internal jugular, or the cranial nerve 11 in any combination, and that's how you call it modified. So going through some of the different areas of the head and neck and what's associated with them. So beginning with the lip, this begins at the junction of the vermilion border and skin. The upper lip, by and large, has very few cancers if you look at the percentages, but the number one most common cancer of the upper lip is basal cell carcinoma, versus the lower lip, where 90% of cancers are found. And the number one cancer in this area is squamous cell. So remember that squamous cell, a lot of times, this is a very good test question because, again, you're learning about head and neck. I just told you a couple slides ago that squamous cell is the most common, and so you might be liable to guess squamous cell for the upper lip, but it's actually basal cell for the most common. Risk factors for cancers of the lip: sun exposure, pipe smoking, and the most frequently involved nodal basins are the submental and submandibular, which makes sense because those are the closest ones to the lip. You can remove up to half of the lip and close the defect primarily without having to do any fancy reconstructions. You do want approximately 3 to 5 millimeter margins, and when you close, you need to line up the vermilion borders as close as possible to prevent poor cosmesis. If the defect is greater than half of the lip, then you need to do some type of flap or different reconstruction option. This is just one example of the Abbey flap. Again, these are complicated surgeries. Sometimes they're staged, so not easy stuff and not stuff we see very often. The tongue, squamous cell is number one, but you can see leiomyosarcomas and rhabdomyosarcomas, but these are rare. Treatment for most cancers of the tongue is surgical excision with wide local excision. Fortunately, if the lesions are very large, you might have to do some type of flap, and a radial form flap. Free flap can actually be used, But if they have large lesions or are not able to reconstruct very well, the patients will have significant dysfunction. They'll have dysarticulation and dysphagia because they won't be able to form that or close the gap between their palate and the tongue to phonate. This is just kind of a representation, really simple for us as we don't think about these areas very often, of just your buccal mucosa and then the gingiva to kind of help you visualize the next couple of slides. So the gingiva is kind of the dental surface of the maxilla and the mandible. Of the gingival carcinomas, approximately 70% occur on the lower gums. Kind of think of this associated with lips, where the lower lip is the most common. If the tumor is adjacent to the periosteum, the patient will have to undergo a marginal mandibulectomy, which is a very comorbid procedure. For the buccal mucosa, these cancers are very rare, about 5%. And again, risk factors: smoking, alcohol abuse, lichen planus, dental trauma, snuff dipping, and tobacco chewing. The palate, you can see some minor salivary gland tumors and squamous cell in this area. The most common intraoral site for Kaposi sarcoma is also in the palate. And malignancies of the hard palate require local excision. One thing that they love to test on is torus palentinus, which is a benign exostosis that may require surgery if it interferes with denture wearing. But this is a picture of the torus palentinus. Just so you can, sometimes they might show it on a test question, and it's a benign finding. Going into the anatomy of the pharynx, so again, you have their nasopharynx, your oropharynx, and your hypopharynx, and then your larynx. So going through the different areas of this and how things are treated. Oropharynx, 90% of the tumors are squamous cell. There's been kind of a switch over the years from less operative and more focused on chemoradiation to kind of preserve this area. Many of the tumors of this area are poorly differentiated and respond well to radiation, and they have found in studies that chemo acts as a radiation sensitizer. But again, sometimes you do have to resect these tumors and do a combination of either radiation or chemotherapy. Hypopharynx, cancer in this area is more common in older men with a history of alcohol and tobacco abuse. The exception to this is in the post-cricoid area. It's more common to have cancer in women with Plummer-Vinson syndrome. So just to remind you that these patients have dysphagia, esophageal webs, weight loss, and iron deficiency anemia. So how you need to treat these is actually treat their iron deficiency anemia and do conservative management for their esophageal webs, and a lot of times you can prevent cancer from forming at these sites. Patients will present with a chronic sore throat, dysphagia, foreign body sensation, but you need to really be careful because these patients, a lot of times, are just thought of as patients with bad reflux or GERD, and so you have to have a high index of suspicion for cancer. Usually you need to do fiber optic endoscopy to diagnose these, and you need to treat this area. You have to do a laryngeal pharyngectomy and bilateral neck dissections and radiation. Again, an extremely comorbid procedure, and I'm not going to go over the details because they really didn't talk about it in the book, and I don't think we'll ever do one of these. Larynx, again, going over some of the pertinent points. So innervation, will frequently show up on test questions. So the superior laryngeal nerve supplies the cricothyroid muscle, but the recurrent laryngeal nerve is motor innervation to all the intrinsic muscles except the cricothyroid. Most common cancer in this area is the squamous cell, again, and it's a very difficult surgery to recover from because of the comorbidities. The nasal cavity, malignancies in this area are rare. Squamous cell and adeno are most common, so remember the major one for all head and neck, you guess squamous cell, but if you're in the nasal cavity, adeno is a little bit more common. Some of the risk factors, so we don't have this anymore, but patients that had been exposed to Thorotrast, which was an old type of contrast agent that patients got with scans, and then people that work in the lumber industry that are are exposed to softwood or hardwood dust, and then those who work in leatherworking are more prone to getting malignancies in this region. Treatment is surgical resection and then either post-op chemoradiation for high-grade lesions. Association, remember, in this area is that nasopharyngeal carcinoma has a strong association with Epstein-Barr virus, especially in Asia. This is a favorite test question as well. Salivary gland neoplasms, they love these on ABSITE, and again, sometimes may pop up on other exams. So parotid gland tumors are the most common site for neoplasms. The malignant versus benign are in a 20-80 split, and again, malignant, there's less common, so they're usually painful. You can have metastatic disease to the lung. Number 1 is mucoepidermoid carcinoma. Number 2 is adenoid cystic carcinoma. Treatment is usually total parotidectomy, modified radical neck dissection, depending on lymph node status and postoperative radiation. One of the things to remember about these is that if they do ask you questions about it, they're basically asking you which ones are malignant and which one's number 1 and number 2 most common. The benign are way more common. At 80%, they're usually painless. Number 1 is a pleomorphic adenoma. You can have malignant degeneration in about 5% of patients or less. And then number 2 is the Warthrins, or the papillary cystadenoma lymphomatosum. You can see this bilaterally in 10% of patients, and they can appear hot, quotes hot, on the technetium-99 scan, secondary to the oncocyte-rich, secondary to the tumor being oncocyte-rich, and they take up the technetium-99. Treatment for these is a superficial parotidectomy. Submandibular, sublingual neoplasms are a 50-50 split for benign versus malignant, and minor salivary glands, more common for them to be malignant versus benign. So if you have to pick one that you would want, you most likely want a parotid gland tumor because they're easier to treat and they're usually benign. As you get to the smaller, minor salivary glands, they become more malignant and in difficult areas to treat. Then they talk about the neck mass workup. If you're not 100% sure what it is, again, doing your physical exam, you do a fine needle aspiration biopsy with using a less than 22 gauge needle. You can do some imaging, and then depending on what the FNA shows, so if it's squamous cell, then it depends where it's at. You'll do some further investigation with endoscopy and then decide how to treat it. If it's negative on the FNA, then you need to do an open biopsy, and then depending on what it is, then will determine your treatment. So neck masses and pediatrics, persistent neck masses, if you were to remove these, about 2 to 15% are malignant versus adults. Persistent neck masses greater than 2 centimeters, about 80% are malignant. So in adults, neck masses, you really want to think malignancy versus in kids. If they persist, you need to keep that in the back of your mind, but usually they're benign. For adults, a midline mass, think of thyroglossoduct cyst, thyroid masses, lipoma, sebaceous cysts, or dermoid tumors. Specifically, thyroglossoduct cysts are a remnant of the thyroid descent. Usually they elevate with swallowing. And the treatment for this is called a cyst trunk procedure, and is excision of the cyst in a central portion of the hyoid bone, which is important to prevent recurrence. I've seen this pop up on tests before. Lateral neck masses, usually think about benign or malignant lymph nodes, carotid body tumors, paragangliomas. You don't want to biopsy these because they're vascular tumor. Branchial cleft cysts or parathyroid cysts. Tracheotomy, the section on this in the book was extremely weak. Dr. Chambers has a much better lecture in his podcast that he goes through, so I would refer you to that for further details. But again, there's the open versus percutaneous dilational technique. Kind of half, there's literature about both. I prefer the open technique. I think you have a little bit better control of the airway, but again, there's nothing wrong with the percutaneous approach either. Vocal cord paralysis, again, a very testable subject, mostly in relation to thyroid and parathyroid surgery. So just as a reminder, your recurrent laryngeal nerves are from your vagus, cranial nerve 10. The right passes around the right subclavian, and the left passes around your aortic arch at the ductus arteriosus. The right, you can have a non-recurrent laryngeal nerve, very rarely, less than 1% of the time. I've seen one so far in my residency. And the left, it's more common to have paralysis on that side as there's a little bit longer course of the recurrent nerve. Unilateral injury or damage or invasion of a tumor to this nerve usually causes voice hoarseness, dysphagia, or aspiration. Treat this, you want to do medialization of the cord, and this can be done with injections or reconstruction. If you have bilateral injury or invasion by some type of mass, you get an acute airway obstruction and stridor, and this requires emergent reintubation or tracheostomy placement. Superior laryngeal nerve injury usually causes difficulty with voice pitch or projection. A lot of times in the test questions, they'll talk about some singer that has difficulty with pitch or projection afterwards, and that would be injury to the superior laryngeal nerve during thyroidectomy or parathyroidectomy. Reconstruction, this is plastics heavy. We have other plastics lecture that I would refer you to. Just as a reminder, a free flap, removal of composite tissue and its blood supply from a distant site, and then bringing it to the site where you want to reconstruct, and hooking back up your arterial and venous supply. The workhorse of soft tissue free flaps in the head and neck is the radial forearm flap. It's based on the radial artery and sphagnum vein distribution. The advantage of this flap is it's thin, pliable, exactly what you need for something in the head and neck, but some of the disadvantages are the donor site is more cosmetically obvious because it's on the radial forearm. So this is the end of the lecture. Again, there's a lot of extra details in the chapter which I didn't feel were very relevant. I would recommend to kind of bolster your knowledge of head and neck to probably look at either information in Cameron's or Schwartz's textbook. I think has some extra information that would be helpful. Again, an area we don't work in a lot aside from thyroids and parathyroids, but sometimes testable information comes up that we need to know. Thank you for your attention. Hope you guys have a great week.